How many of you have looked at a systematic review before? Have you looked into them, or do you know what they are exactly? Or meta-analyses? Okay, so what we'll do here is there will be a scenario, and we'll go through the same kind of questions and so forth, but what you should be viewing these questions in these handouts as is this: that when you have a paper, you don't read through the paper like a novel, okay? That will be a total waste of time. It'll take way too long for you to read the paper as such. Instead, what you do is you have in your mind a series of questions that are demanding answers, okay? So you're looking, I have a bunch of questions about this paper that need answers for me to do the critical appraisal. That list of questions are the questions in your handouts. But you probably have noticed so far that the list of questions is different for every study design, okay? So each study design, you're going to be asking a different set of questions. The other piece to it is that you have to understand the anatomy of a paper. Where do I go to find the answer to this question? Where do I go to find the answer to that question? And so what you're doing is, most of the time, the answers are found in a certain place in the paper. So I know that the population comes first in the methods usually. So if I have questions about who got into the study, I go there. If I need to know what PICO is, I go to the title, then the abstract, that kind of thing. So where do I find out about randomization? Where do I find about follow-up or intention to treat? You need to learn the location of those questions in the paper, okay? Another aspect is that when you're doing evidence-based medicine, you have to frame the question. And it sounds kind of like kindergarten, right? I mean, PICO, it's 4 letters. It sounds so simple and easy. One, it's not always so easy. Sometimes it is. But you should look at it this way, that you start with a patient scenario. So you have a patient and they have something, and you need a question. You need an answer to a question. So you develop PICO for that patient, okay? And then what you do is you use those search terms, use the terms from PICO as a search strategy to find a paper. Then you find the paper. Now you have a paper in your hand. You have to find PICO for this paper. And then you try to match and see, does PICO from my paper match the PICO that I'm trying to find? Okay, so that's kind of an overall strategy of how to proceed in all of this. All right, so now systematic reviews are different from other study designs, but has anyone seen this pyramid before? Are you familiar with it? This is like the evidence pyramid, and at the bottom are things like expert opinion and experience and editorials and things like that. Okay, then case series and case reports. These don't really give you much evidence, okay, as such. Then you come into, from this level up, you have observational studies, case control studies, cohort studies, and cross-sectional studies here. Now, there are a lot of questions, like questions about harm, for example, you're mainly going to find in this level, because you're not going to get much in the way of randomized trials. It'd be unethical to randomize people to something that you think is harmful. So, now of course, randomized trials are used to answer questions about interventions, right? Now, systematic reviews are put up top here because what they do actually is to gather the results of multiple studies, okay, into one study. And then they get a weighted average of the results of all the studies. So now the thing about this is you can have systematic reviews of cohort studies, systematic reviews of case control studies. But the most common is is systematic reviews of RCTs. Why do you think that is? Why do you think most of the systematic reviews out there are reviews of randomized controlled trials and not observational studies?
Because the rest were excluded of the study.
Well, yeah, this is kind of like, what am I thinking? But the reason is because just because it's a systematic review and you see this up at the top does not mean that it's the best evidence, okay? And the reason is this, that, have you heard of the term GIGO, G-I-G-O, before? Okay, that's garbage in, garbage out. So if you get a bunch of garbage papers, whether they be cohort studies or randomized trials or whatever, and you put them all together, you make a nice systematic review of garbage, you'll have a garbage systematic review. So that's the first thing to remember about a systematic review. Garbage in, garbage out. You can't fix the problems of the source studies that you're combining by combining them. So if you have a biased case control study, combining it with other biased case control studies won't fix the bias. Okay, same thing if you have a confounded cohort study. Combining it with lots of other cohort studies does not take care of the confounding. You'll have a confounded or biased systematic review. That's why, what happens to bias in a randomized controlled trial? Well, the whole study design is meant to do what in terms of bias? Well, remove is a really strong word, but to minimize the bias, you try to do things like randomization and blinding and intention to treat and all of these things to minimize the bias, okay? Now, randomized trials can also be biased, right? But they tend to minimize the bias. So that's why if you combine a lot of high quality randomized controlled trials that you say have very little risk of bias, then the result that you bring out is going to have a systematic review with low bias. Okay? What do you think the advantage is to combining the results into one study? What do you think?
The sample size.
Okay, that's it. The sample size is greater, so what happens to the confidence intervals? The accuracy, or more the precision, right? The precision is increased, meaning what happens to the confidence intervals? If you have 10 studies that have confidence intervals like this and you add them all together, it's going to narrow the confidence intervals. You will have more confidence in the result. Okay? So that's the idea here. Now, what are systematic reviews? See, there are lots of reviews in the literature, okay? But not all of them are systematic. So a review of the literature is not a systematic review. What does it mean to be systematic? It means, does anybody know what it means to be systematic? What's that? It follows a system. Good. That's a good English equivalent. But what does it mean in terms of these reviews? What do they do to make it systematic? Okay. Okay, there's one word you said which captures it, is all. They attempt to get all the studies on this topic. Everything that's been published on this topic, if you could get it together, then that's a systematic review. So they systematically search the literature to get everything on this topic. If I'm writing a review for postgraduate medicine, I might pick my favorite articles and reference those, but I'll leave off the ones that I'm not so interested in. Systematic review says, no, I have to capture all of them. So that's what makes it systematic. So other ones that are not systematic are called narrative reviews, okay? And so what a systematic review does is it's a strategy to democratize the literature. Meaning if you have a less well-known study and a well-known study, they still get a seat at the table. And providers, policymakers, you know, they can't keep up with all of this evidence. So what this tries to do is to try to bring it all together in one place. All right, and now, doing this sounds easy. I have people, probably it's once or twice a year, that people come and say, I want to do a systematic review. Can you help me with it? And I sit there and I think, you have no idea how much work this is. This is a huge amount of work to do this, okay? So it's a method to identify completed studies addressing a specific research question and to evaluate the results. Actually, more than just evaluate, but to combine the results using a method called meta-analysis. So a systematic review is a systematic review if it attempts to capture everything. It becomes a meta-analysis when you combine the results into a single estimate and confidence interval. Okay, that's what a meta-analysis is then. Okay, it's the statistical aspect which you're combining it. Meta-analysis is the statistical procedure to give weighted averages to all the studies. So what they do is they search, they identify, they select, they appraise, and they summarize all the literature that's available, if it's well done. Okay? Now, so quickly, here's the other thing about systematic reviews. They're very focused. They focus on one or a few very narrowly focused questions using what framework? What framework do they use to make that question?
Keywords.
Well, keywords, but what's our framework for the question? PICO. Okay, so PICO or PICO. Whereas a narrative review could be management of diabetic foot, right, which has 10,000 different aspects to it. So the reviews that you see, the narrative reviews, tend to be broad topics of interest to residents and things. But a systematic review has a very focused question. The search criteria are explicitly laid out in this, and the selection of what literature you're going to review could be very subjective in this kind of review, but it's criterion based. You find everything and then you have very specific criteria for which papers get into your systematic review. And usually this systematic review is rigorous, okay? It's designed to be rigorous. And then the synthesis of the data is often attempted. The meta-analysis part where you synthesize and you combine all the results, sometimes it just doesn't make sense to combine everything if things are too different. Like if you're going to be mixing apples and oranges, okay, that's going to be a problem. It's kind of like saying, well, I have this hand on the fire and this hand in the freezer, and I just feel really good, right? If you're trying to mix two things that are really very different, and you say that's the average, do you see how it could be a problem? You can't mix things that are too different. So the issue, that's another issue, is something called heterogeneity or homogeneity. And there are two levels of that. One level is in the design. Okay, if the designs are close enough to each other, then you can combine. But you have to decide. Let's say the dose in this study was 60 milligrams and the dose in that study was 90 milligrams. Can you combine them? Well, you have to decide. Sometimes there are these little differences, but if you know, it was drug A in this study and drug B in that study, combining them doesn't make sense. So you see what I'm saying? You have to be really careful about heterogeneity. Okay? So that's one type of heterogeneity. That's qualitative type of heterogeneity, which is difference in the study designs. And then the other one is the issue of results. If you have results that are way too different from each other, you don't, you know, you may not have the right to combine them if the results are so different. If one study shows that this medication is very harmful and the other study shows it's very helpful, you combine it and it says it does nothing, that doesn't make sense. So maybe they do the meta-analysis, maybe they don't. Okay? And then So the inferences that come out of this, of course, you're doing this very rigorously, so you want it'll be more evidence-based type of results. So when you look at a systematic review, there are 3 sections. They talk about the critical appraisal. First, you want to say, are the results valid? Well, how would you go about asking those questions? The validity of a systematic review fundamentally is based on the validity of the source studies. And then the validity of how well they searched the literature. Did they get everything? Did they do everything that they possibly could to capture all the literature here, or are they ignoring some? Okay. And there's another threat. We've already talked about 2 threats, right? GIGO, garbage in, garbage out. We've talked about heterogeneity. Qualitative heterogeneity in the study designs that you're mixing, and quantitative heterogeneity, which is combining studies with 2 different results. This third one is something called publication bias. And what is publication bias?
Published or non-published?
Okay, so let's say you have a study, you're the author of a study, and it shows that drug A reduces the incidence of disease by 50%. Would that be published if you find a big relative risk reduction?
Yes.
Yeah, but if you have a really large study and it shows no difference, do you think that would be published? A really large study that was funded by the NIH and it says this medication does nothing. Do you think that would be published? Yeah, sure. What about I'm an individual investigator, I did a small study and I didn't find anything. Is that likely to be published? No. So it's the small studies that show no effect that are the ones that are out of the literature. So if you include the small ones that have an effect and the large ones with less of an effect, you're still going to get a bias toward the effect side. So that's another threat to a systematic review called publication bias. And then, so we're going to talk about the validity, and then we'll talk about what are the results, okay? How to assess the results, and we'll look at something called a forest plot. And then, are these results applicable here? All right, now, remember all the list of questions for randomized controlled trials and cohort studies from yesterday. Well, this is the list of questions for systematic review. Now, we're not going to necessarily go through every one of them. We'll go through the list on your handout. But how clear is the question, right? How comprehensively did they search? What were their criteria for accepting a study? Did they include some kind of assessment of the validity of those studies? Did they look at the quality of the studies? Did they measure the quality of those randomized trials? And were those validity criteria reported? Then, how similar are the groups and the treatments? Remember heterogeneity, qualitative heterogeneity. Are the treatments similar enough? You know, did they explore why there might be differences between these? Maybe this study is in older patients and this is in younger patients. Can you combine those? You have to think and decide whether you're going to do that. And then data synthesis. Did they combine these data from all the results from them or not? And did they document what review type methods that they did? Like, did they have 2 reviewers independently reviewing all of these things and then reporting their results and then seeing if there are any differences? Okay. And then what kind of summary did they have? Did they do a meta-analysis that shows the combination of all of these? Okay. So any questions so far about what is a systematic review and how, what are the questions that you're going to ask to do the critical appraisal? Any questions? Okay. So let's get to the scenario. Now this is a really long scenario, but could somebody, I guess maybe we should just read it and someone summarize this case. How many people read it already? Did anybody pre-read? Anyway, you've got to read before, don't you think? So, but I kind of suspected that because most of the time people aren't reading before these things. Anyway, I don't want to spend time just reading it, but reading it out loud. But somebody summarize this paragraph. What did you see?
One patient undergone tooth extraction and asked the physician if she needs to take antibiotics.
Okay, good. So after the extraction, she's asking, should she take prophylactic antibiotics? It sounds clinically important to me. I mean, if I were having my tooth out, you don't know if you can help her. So you do a quick search. And you find this Cochrane review. Okay? Now, how many of you have heard of Cochrane, the Cochrane collaboration? Anybody? Okay. So the Cochrane, Archie Cochrane was a clinical epidemiologist who said, look, all of these randomized controlled trials are being published, but no one is there to bring them all together in one place. So that's where they started. They started by collecting randomized controlled trials. And then through that collaboration, this method of systematic review and meta-analysis have been developed. So the Cochrane library is really the best place to find randomized controlled trials and systematic reviews. And the thing to remember, kind of a fourth thing to remember about these things, is that just because it says systematic review on it doesn't mean that it necessarily was done well. And that's where the critical appraisal comes in, okay? However, if you see one done by the Cochrane collaboration, you can trust it, okay? I think I can say that for sure. If you see Cochrane collaboration, systematic review, they know how to do them, and they do them well. There are lots of people out there doing meta-analyses, not doing a very good job. So at least this one, if you find it there, that'll be the best evidence. So let's start with PICO, with this patient, okay? So let's frame the question as population, intervention, comparison, and outcome. So what do you think? Let's do population first. Okay. Patients with tooth extraction. Okay. Among, and you know, when you talk about population, say in patients who have been having a tooth extraction, does what? Okay. Yeah, so either prophylactic, antibiotics, okay? Compared to what? Compared to none. Now, the comparison group, don't forget about this comparison group. It's actually quite important. Because if there's a standard therapy, you need to compare it to the standard therapy. And then always look to make sure that they're actually giving the standard therapy, not something else. Because if you want to compare this new drug to the old regimen, if they don't give the old regimen properly, maybe it will make the new one look better. So you have to be careful about that. But is there a standard therapy for tooth extraction? Standard antibiotic or anything like that? No. And then what's the outcome? Okay, infection. How many of you are dentists? Any dentists here? Okay, we're going to depend on you a lot. Okay? So what are the outcomes here of importance to a dentist? Infection? Necrosis. Necrosis. And then I read something about dry socket. So is dry socket kind of a combination of these two, or just an infection? Okay. Okay, so now it's critical whenever you're doing critical appraisal to force yourself to do this. Okay, you've got to do it. And then now you have certain keywords here, right? And that's upon which your search is based. So I'm in PubMed, and you tell me what to type. What shall I type into the box in PubMed? So what would you put in here? Okay, so we've got tooth extraction, prophylactic antibiotics, infection, and necrosis. So how do you, and anytime you do this, you have this whole range of terms on the page. How do you decide what are the most important ones? Okay, yeah, if it's an intervention, that probably is good. But what I do is I do this little experiment in my head. I say, I'm going to pretend that I did this study that I'm looking for. And I'm going to say, if I published this, what title would I give it? Okay? And then I would say, among these words, which ones must be in the title? You could not write the paper without that word in the title. Okay? So, among these words, which ones would have to be in the title? Okay, yeah, so I think antibiotic probably would need to be in there somehow. I mean, how could you write a paper about prophylactic antibiotics if you didn't put the word antibiotics in there? Now, the problem is maybe they say clindamycin, right? There are synonyms for this, so you might get a little sidetracked if you just require antibiotics. You have to think about the synonyms for these words. What about prophylactic or prophylaxis? Would that have to be in the title? Well, antibiotics after tooth extraction. You could think that it might. It could get away without that. How could it be? Does infection have to be in there, or necrosis?
No.
No, you could write it without. What about tooth?
Yes.
Okay, tooth. Tooth would have to be in there, or teeth. Tooth or teeth. So you have to think about those. So I would, the way I would start would be to say these two, tooth and antibiotics. And you think about it, you think, well, yeah, those are kind of the Zibda words, right? Now, how would I write it out here? So I put tooth, and then do I put and or what? And so, have you had the session yet? Yes. Oh, you did. Okay, so you'll be all over this. Yeah, you want capitals because sometimes PubMed is tricky. It doesn't always like lowercase, especially if it's a complicated search term. So tooth and antibiotics, okay? Now, how many articles do you think would come out if you just put tooth and antibiotic in there? What's that?
Too much.
Yeah, quite a lot. Okay, why? Actually, if you think about it, where is this actually searching in the paper? Like you have a paper here and you're searching. Where is it actually searching? It's looking for tooth and antibiotic in the same paper. Where? Anywhere in the whole thing. It could be in the abstract, it could be anywhere. So do you think there may be some paper that has the word tooth somewhere in the discussion and antibiotic somewhere in the method or something, and it would find that, right? So what's the way of narrowing this down really solidly? Yeah, the title. So remember we said, in the title. So now we restrict it to the title. How do you do that in PubMed? Do you remember? Square brackets, and you put title like that, okay? Very good. And then antibiotic title. See, that's really good there. And so now what you're finding is papers that have the word tooth in the title and the word antibiotic in the title. And you see, you don't need all of these terms to find articles of relevance. Now, sometimes you're going to have to expand the search, but the place to start, at least just see what you get, like this, and then move forward, okay? So now we've done that, and we find, and in in this particular case, we're looking for systematic review. So we either go to Cochrane Library, search for systematic reviews. How do you do that in PubMed? Do you remember? Yeah, through these filters you can find the systematic reviews. Okay, so you do that and you find this one. Where's my, here. Okay, so here's the PICO that we did, and you find this one, and you're very glad to see that it's a Cochrane. Now, the problem here is that Cochrane has not done systematic reviews on every question in the universe. You know, they just have done them on a certain number. They keep doing more, and you know, they are interested in getting feedback from people about what questions need to be done next. And actually, this collaboration is all over the world now. There are groups all over the world who are doing this. Okay, so we start with the question about the validity of the results. So what are some of the things that we want to know? The first is, how clearly did they define the question? Because now we have our PICO, and we want to see, does this systematic review match our question? And let's just see here. Antibiotics to prevent complications following tooth extractions. Wow, that sounds pretty relevant just from the title, don't you think? Okay, and would our search have found it, by the way? Tooth and antibiotics, okay? So, and I would have searched antibiotic star, because you could say antibiotic prophylaxis without the S. But if you put antibiotics, it would exclude something that said antibiotic prophylaxis. So you have to think about shortening those words and making little stars to, so antibiotic star would pick up antibiotic and antibiotics, okay? Now, here we go. I'm gonna have to flip back and forth between these slides here because I want to show the page. So is the specific purpose of the review stated? What I want you to do is to take a look, and we have a little cheat sheet here on page 1. Can you find where it says anything about the purpose? Look carefully at page 1.
I didn't attend the debate, so I don't know about the paper. So I don't have it. So
Oh, you don't have the paper?
Yeah.
Okay, okay. I'm not sure. Did you get the? It's online, yeah. Yeah. Okay, so try to find where they say something about the purpose of the review. Anybody? Can you see it? What does it say?
To determine the effect of antibiotic prophylaxis on the development of infectious complications from tooth extraction.
Okay. Let me just see, where's page? Oops, I passed it. Okay, so here it is. And yeah, so under objectives. So can you get PICO from this paper so far? To determine the effect of antibiotic prophylaxis on the development of infectious complications following tooth extraction. Does that have PICO in it? What's the population? Tooth extraction. And what's the exposure? Antibiotics. And the outcome? Infection. So at least on the first pass, this looks like it really is matching my PICO. Okay. Now let's go back here to this. So is the review question clearly and explicitly stated? Now that was the objective, but we want to say a little bit more clearly. And let's go to page 6. Can anybody see on page 6 where they come a little more clearly to the objectives here? And actually they have several objectives, and we're interested, do you see here? To assess the effects of antibiotic prophylaxis on the incidence of infectious disease. That's almost a restatement of the first thing that we saw in the abstract. And then here, to look at the same thing in immunocompromised patients. So now they have a second question in this review. And if we go down, what's the third one? Yeah, so they're looking for maybe some particular procedures. And now our dental representative here has to tell us that maybe if your tooth extraction type is wisdom teeth or impacted teeth, maybe that's a different scenario than if they weren't wisdom teeth or impacted teeth. More complicated, okay. So they're looking at immunocompromised patients, they're looking at complicated cases, and they're looking generally at the sort of the general cases. Okay? Any questions so far? So this is actually how you do it. This is how you go through the systematic review. You look and see what are the questions. Does it match my question? Now, so we've done our PICO. Now, the next question is, was the search for relevant studies detailed and exhaustive? It's really critical that you look at how they did this literature review, because there are so many aspects to it. It's not just doing a quick PubMed search. It's looking at PubMed and Cochrane and other sources. And what they do is they first gather any paper that possibly could be related to the topic. So they're going to get a lot of papers that are not related to the topic, but they collect anything that possibly could be related, okay? And then they do a screen. They abstract data from all of these, right? And they say, what are the criteria? What were the methods that they used? And did they do randomization or not? And maybe their criteria will be, if they did not do randomization, they're going to throw it out. So you have to look and say, well, what criteria did they use to find all these papers, and then to limit these papers down to ones that they're going to include? So it's a multi-step process, okay? And let's take a look. Plus, once you get papers that are relevant, then you start searching the references in those. And then you pull those, and then you look at the references in those. And so after a while, the references are all going to be referencing something that you already have, okay? And there are other things that can be done as well, which we'll get to in a minute. So somebody look up, actually everybody, on page 7, okay? And okay, this now is to the methods of the systematic review. And you tell me, what type of studies did they include? What did they include, and did they exclude any? Okay, so randomized controlled trials with a double-blind design, okay? Okay, so they did crossover studies. Do you know what a crossover study is? Okay, so what they do is they randomize to antibiotic versus no antibiotic at one tooth extraction, and then they see what happens. And then they wait 6 weeks, and then if they have another tooth extraction, then they flip it. Same person, but they flip to the other side at the second tooth extraction to get what they didn't get in the first one. It's a crossover study design. So, but they said it has to be at least 6 weeks wait, because you want to get the effect of that antibiotic out of the system if they were on the antibiotic, okay? So now, so here, who got into the studies? Who did they allow to get in? Because that's very important. The population is very important for you to understand who got into this study, whether it's a randomized trial or systematic review. And say anyone undergoing a tooth extraction. They didn't say adults, they didn't say anything, male, female, anyone, including extraction of impacted teeth. okay? Are you with the study so far? You say, I need to know about this study. I need to understand it. Then what were the regimens or the interventions that they were looking for? What did they look for? Okay. So does it matter whether you get the antibiotic before or after, or before and after? For you it matters, right? And so what they're saying is they're going to look at any trial that had it either before or after, or before and after. Now what they can do is when they gather these trials, you can do a meta-analysis on the whole thing, and then you can do subsets. You could do a meta-analysis on just the ones that had it before, and then do another meta-analysis on those that did it after, and then another meta-analysis on those that did it before and after. Okay? So, but do you see, if you combine all these together, there is some heterogeneity, right? Do you feel comfortable combining these three types together into one meta-analysis? Well, so we'll see what they do. We'll see what they do. Do they put it all together in one? Or do they stratify it? Or do they do it both ways? Okay? So we'll have to see. All right? Then, while we're at it, let's just look at the outcomes that they're looking at. So what's the main outcome? The main outcomes are, so alveolar osteitis, something infectious, something that suggests an infection in the tooth. Okay? All right. Then we're going to go up here. Oops. And we're going to look for the search method. So you tell me whether you think this is a very broad search method or just a very simple method. What do you think? Where did they go looking? This is how you actually do the critical appraisal of this. Read this and you tell me some of the things that they did, that they looked for. Some of the search engines. Anybody? So what do we have here? Okay, so we have Medline, we have Cochrane, and EMBase, Lilacs, okay? And so they're looking at a broad range of databases, okay? Then let's look at their search. The search string, if it says here, details of the Medline search is provided in Appendix 3. Now look over there at our search, right? Tooth in the title and antibiotic in the title. Let's see what they did, actually. Here it is. Okay, this is how they did it. See, all of this. Tooth and all text near for extract in all text, or teeth and this or that or that or that. Now that's a search, okay? And then that's just number 3, and then they did number 4, and then they did number 7, and then they did 9 and 10 and 11, 12. They did a lot of searching. Does that impress anybody? I mean, again, don't think this is an easy process. Then, do you see what they did? Remember I said about antibiotic, you're going to lose clindamycin, or, you know, they did metronidazole, tetracycline, clindamycin, teicoplanin, vancomycin, floxacillin. So they did searches on every antibiotic that could possibly be used in prophylaxis. And then Here's the Medline strategy. And look at that. Okay, several pages. This is the Ovid strategy. Several pages, and then this is the Lilac strategy. Okay, you get the point, right? This is a huge effort, and you look at that and you say, well, do you think they did a good search strategy or not? Was it pretty comprehensive? Absolutely. And then they did more. Hand searching. What's hand searching? Well, actually, hand searching, they actually went through these journals, issue by issue, looking at every single title. Okay? So, and they should say what years they did. There were no restrictions on language or date of publication. They went through British Journal of Oral and Maxillofacial Surgery. They went through British Dental Surgery. And they actually paged through and looked at every index on every issue in these journals. Okay? Anybody want to say mashallah for that? I mean, okay? So the hand searching was done as part of the Cochrane Worldwide Hand Searching Program. Okay? So they probably had multiple people doing this. And then what did they do? Reference lists of all eligible trials of existing reviews were checked. So the references on all of these trials and the reviews were checked. Okay? Then what did they do? The first named authors of all the included trials were contacted in an attempt to identify unpublished studies. You know, you published this study on this topic. Did you have another trial that never was published? Do you see? So they emailed everybody. And also to obtain further information about the trials that were included. Okay, so is anybody getting the idea that this is a lot of work? Okay, so my hat's off to them for doing all this. Okay, then how about the selection of the studies? Now they've gotten all these studies, how are they going to select them to get them into this thing? Here it goes. The title and abstract of each article resulting from the different search strategies were examined independently by 2 reviewers. Not one person, but 2. And then, where studies appeared to meet the inclusion criteria, okay, they had to be randomized and they had to be blinded. Okay, randomized control trials. Then, if the abstract wasn't enough to give them the information, then they read the whole paper. The full report was then assessed by at least 2 reviewers. Any disagreements between these reviewers saying, yeah, I think this one is eligible, and the other person says, no, it's not, then they will get a 3rd person in to break the tie. And they would have a discussion and decide, is this eligible for our meta-analysis or not? Okay, then it says studies rejected at this stage were recorded in something, in this characteristics of excluded studies. So anybody who says, well, you didn't include mine, so they say, well, go over here and we'll say exactly why we didn't include your study. So anyone that was excluded, they have a justification for why they didn't include them. Okay? So the first step is you do PICO. The next step is to say, how did they do the searching? How did they do the selecting? What were the inclusion criteria for the studies? And, you know, then how rigorous was the search? So let's answer these questions. Was the search for relevant studies detailed and exhaustive? Fine. We've convinced ourselves of that, right? There's another thing they did. They looked at conference proceedings. And, you know, if there's the British Dental Association conference, ADS, okay? And so say they had a conference in Zurich, and then you have all these people coming from all over the world, and they present their abstracts, right? Well, is it easier to get your study published in an abstract or in a paper, in a journal? Abstract. So don't you think there may be some small negative studies showing no effect that were presented at some conference, but were never published? Sure, so that, they also did that. They went to conference proceedings. Okay, we read this already. We read this. That appendix, page 67 to 70, had all those search terms, okay? The hand searching, the reference lists, etc. Okay? Now, we get an idea from this flow chart, how many journal articles were there? So they found over 1,000 articles, and they started the abstraction process, okay? So 1,053 were screened, 997 were discarded as not relevant, okay? They said this topic of this paper is not relevant here, okay? Then, so there were 56 left. And then 37 of them were excluded for some reasons, like maybe there wasn't randomization, or maybe there wasn't blinding, or whatever, okay? And then out of it, 16 studies met the inclusion criteria. So look at that. They started with 1,000, and they ended up with 16. A lot of work, okay? And then here, 2 further studies identified from searches of the reference lists were included, so it came to 18, okay? Then, whoops, let's see here. Okay, so that's where we are. It's how they got them into the study. Then, now, look under page 10, go find page 10, and you want to say, did they assess these papers, these 18 papers now, because now we're down to 18, did they assess them for the risk of bias? Okay? And how would they do that? How did they assess them for risk of bias? Okay, so Cochrane actually has a risk of bias assessment tool. And what are the things in that tool? What are the issues that they're concerned about that, say, a randomized trial would be at increased risk for bias if what? What's that?
The random sequence generation allocation.
Okay, so how did they do the randomization? And then was?
Allocation.
Yeah.
Allocation, concealment. And
Concealment.
blinding.
Yeah, so do you remember concealment? The difference between concealment and blinding? Right? 2 different things. Okay.
The blinding and the completeness of outcome data.
Yeah, completeness of outcome data has to do with what? What is completeness of outcome data? I think they call it attrition bias or something. Do you remember losses to follow-up? Okay. And then, so if you think about just the validity criteria for a randomized trial, 4 main areas. One is randomization. Did they do it correctly? Did they conceal it? Blinding. Were the people or the investigators blinded? Follow-up, was there sufficient follow-up and reduced or minimizing the losses to follow-up? And then intention to treat. I'm not sure if they included intention to treat here or not, but let's take a look. So here we go. Did everybody see this graph? So green means good, yellow means maybe, red means bad. So, and then here are our validity criteria, okay? And these are the studies. So some of them are mostly green, others have a little yellow. There's not too much red, but the red seems to be focused more on incomplete outcome data or selective reporting, where they report selective parts of their study and not others, okay? And then this is an overview, it's a summation of all of those. And so it looks fairly good, but again, with this losses to follow-up and the selective reporting, there's a little bit here that's a problem, okay? So this gives you a sense of the risk of bias. my sense here is that these main ones here, which are the most powerful parts of this, is that it's a reasonably low risk for bias in this systematic review, though there's a little bit there. Okay, but you have to get a sense of it. All right. Okay, so remember the garbage in, garbage out. If you put garbage in, you're going to have a garbage, and this is where you check it. This is where you check for bias. Okay. After bias, what's the next step? Heterogeneity. Okay, so did they look at, were these study designs similar enough to really be justified in combining them? Okay, so then we're going to look on pages 12 to 15, and you say, were the study designs of the studies similar enough with regard to PICO to combine? Do they present the details of each of the studies to see if you can just look at them and you see whether they're similar enough or not? Look on page 12 to 15, and what do you see on that page? Let me take a look here. I think it's the next page. Yeah. Okay. Is it? Let's take a look here. Yeah, but here, actually, look here. It says, for a summary of characteristics of each of the included studies, see this characteristics of included studies table. That's the one I like to look at, where they have a table and they have all the studies there, and they say, what was the population, what was the percent male, and then what was the dose of antibiotic, what was the type of antibiotic, and what was the outcome and the result. So I'm going to click on that. I'm not sure what page this goes to. Yeah. So here, you actually have a comparison. I mean, the details of every study right there in front of you. So this one was the intervention was looking at 1 hour pre-op and 7 days post-op. So this was one before and after. Okay, and what did they use? Either azidocyline, or erythromycin, or doxycycline. Okay. Then let's look at this next one. McGregor here. This was pre-op penicillin versus placebo. Okay. So that's a bit of a different antibiotic. And this is pre-op, not both, right? And you can go looking at each of these studies and say, how similar are these studies? Do you see how there are differences, right? Then you have to ask the question, can I combine these? What do you think? Do you feel comfortable combining them? And you have to think clinically. Clinically. Does it matter whether someone gets clindamycin or penicillin in the end? Or erythromycin? The answer is not yes or no. It's a clinical judgment, okay? They certainly, it appears, they felt comfortable saying antibiotic, any of the above, would be good enough to include it in. They weren't saying this type of antibiotic versus that type. They're just saying antibiotic, okay? But do you see, you have to decide, is it justified to combine all these or not? Okay? Let's go back to page 15. Okay. So all of these pages are giving you some information about, 4 studies reported the development of dry socket within a follow-up of 7 days, and a follow-up of 7 days and 8 weeks. And then another one had follow-up between 2 and 4 days. And then another had follow-up at 2, 5, and 7 days. And again, what do you think? Can you combine something that had this kind of follow-up versus this kind of follow-up? What do you think? Well, think clinically. I mean, if I'm capturing 2, 5, and 7, so I'm getting it at 1 week. This is a follow-up at 7 days, so I'm getting some of the same thing here. This one is 2 and 4 days, so there's some overlap here. You see, you have to think clinically. If I had a dry socket or if I had something, would it last 7 days? What do you think? Does it usually last 7 days? What's that?
Usually it happens shortly after.
Yeah.
It can be something that's longer.
Right. Most of these are looking at several days after. So if I look at it at 2 and 4 days, and another person looks at it at 7 days, are you going to think that you're capturing the outcome differently enough that you couldn't combine it? That's the type of question you have to ask about it. Do you see what I'm saying? Okay. Now let's go back to the slides. What time do we finish?
12:30.
12:30. Okay, so we still have 20 minutes. Then we get to the data synthesis and the results. Okay? Well, before we get to that, here's another quality control. So we conducted a meta-analysis if the studies were of similar comparisons reporting the same outcome measures. Okay, so this is kind of what we're getting at. Are they similar enough to combine? We combined risk ratios for dichotomous data and mean differences for continuous data. And then they did something called random effects models, which I don't know if we'll get to that or not. Okay? And we already did this risk for bias. Then they did another thing, which is called a sensitivity analysis. Now, this kind of analysis, anytime you see the word sensitivity analysis in the literature, it does not have anything to do with diagnostic tests, sensitivity and specificity. An analysis that is a sensitivity analysis means that they do the analysis one way, and then they do the analysis the other way, another way. And they see if the results are different based on whether they did it this way or that way. Okay, that's a sensitivity. And a way to think of it is the result itself sensitive to the method that we used? Okay, so what are they doing here? What is the sensitivity analysis? What do you think they're doing that, and why are they doing that?
To correct the statistics of each article.
They're not correcting anything, but what they're saying is we're going to do the meta-analysis this way. And then we're going to do it another way and see if there's a difference. What's the one way and the other way that they're doing here? Well, what do you think if we go back here? They're going to do it with all the studies one way, and the other way they're going to exclude some studies. Which studies will they exclude? They'll exclude this one. Why? And they'll exclude this one. They may exclude this one. They'll exclude the ones with higher risk of bias, right? So they're going to do it two different ways. They'll do it with all the studies, and then they'll do it with the high-quality studies. They'll say, well, let's see if excluding those ones that have higher risk of bias makes a difference. Because if it does, it may be that this result we're getting here is biased. Okay, so they're doing it with and without. Okay? With and without those people. Okay, now let's take an overall look at this. Do you think that so far that the results are valid? So the questions are, did they do an exhaustive search? Did they try to find unpublished studies? Did they include only high quality studies? Did they do a sensitivity analysis on these studies? Did they do their best to combine studies that were of similar nature? You see what I'm saying? Okay. So do you think these results are valid enough to keep going and to say, well, I guess I'll trust this one? What do you think? I think I probably would, especially the way they've done it is really an excellent way. And the studies they're getting seem to be high quality. Okay, so now we get to what are the results. Okay, and this is found on page 4 and page 19. So I think page 4 is, yeah, it's oh, I can't rotate the page? Oh well, I think it's in the PowerPoint slide set. Okay. Here we go. So, this is the overall result of the study. Okay, and what we're going to find here is the outcomes. So we've got local sign of infection, dry socket, pain, fever, and swelling. Okay? Let's just focus on this one, which is the main outcome, the local sign of infection at 7 days. Now, what we have here is the risks, okay? The risks in the placebo and the antibiotic group, all right? So what we have here is 118 per 1,000 and 34 per 1,000. What are these numbers? What is the nature of this number, 118 per 1,000?
Number of the cases?
Yeah, the number. What's the technical term for it, though? Incidence or risk. Risk and incidence we can sort of equate, okay, usually. And so you have, this is assumed risk. This is the incidence of infection. For every 1,000 cases, there were 118 infections. And then over here, 34, okay? So just on the surface here, it really looks like this is a big reduction. Right? So they now calculate the relative risk to be 0.29. And how did they get this? How did they get this 0.29? Yeah. So this is the relative risk equals 0. So you take this one divided by that one, right? So it's 0.034 divided by 0.118. Okay, and that will equal the relative risk of, 0.329. Okay. Now, when you're looking at a relative risk, what are the 3 things that you want to be looking at? Okay, so comparing to 1, meaning how big is this risk difference or the relative risk? How large is the effect? Would you say this is a large effect or a small effect? A large effect on a relative scale. So you look at the relative risk and you say that's a large effect. What's the relative risk reduction here? 1 minus that. It's the distance between 0.29 and 1, right? So that's about 0.71 or 71%. So now we have a 71% relative risk reduction. Then you say, well, these are in relative terms. Let's think of it in terms of absolute terms, right? So if you have, let's say this one is, what was it, 0? 0.034, and this one is 0.118. You have two incidences. You can get the number needed to treat. How do you do that? If you have two incidences, you can get the number needed to treat. So what do? You subtract. What you do is you take this difference, right? Take that difference, and do what with it? 1 over that difference. Okay, so what's the difference here? 18, 16, 84, right? 0.084, I think that is. Somebody calculate 1 over 0.084. So this is what is this number here? This is the absolute risk reduction, right? So anytime in a paper you see two incidences, you can get the number needed to treat. Just take the difference between them and go 1 over it, okay? So what's 1 over number needed to treat is 1 over 0.084, and that equals what? 11.9 or 12. What does that number mean, 11.9?
Treat 12 patients to get the reduction in risk.
Very close, very close. You need to treat 12 of these people to prevent one what? One infection, okay? Yeah. So you need to treat 12 people with antibiotics, either pre or post or whatever, in the perioperative period, to prevent one of them, right? One outcome event. What's that? One local infection. You can do the same thing for dry socket. You'll have to treat a lot more, right? Because the relative risk is 0.6, and this is a much smaller difference, so you'll end up treating more. Okay, so yeah, we already did this. What is the number needed to treat? Okay, let me back up. So we've got, the way you approach this is you want to look at the relative risk reduction. You also want to look at the number needed to treat, because they both give you two different pieces of information. One is a relative piece of information. The other is an absolute piece of information, okay? And if you just think about it, forget about antibiotic resistance. Is number needed to treat of 12 usually a reasonable number? Usually it's a reasonable number. Now, you have to bring into the equation, how important is this outcome? How bad is this outcome? And you need to be a dentist to tell us whether this is a really bad outcome or is it something you can just deal with, right? Because why not just let people get their dry socket and then treat it? Why do you need to treat 12 people when they'll come back in 2 days and say, I still have pain, and then you treat it then? Do you see what I'm saying? And what happens to those people if you would wait? You know, if it resolves and it goes away, are you really doing anything? Are you really helping the patient that much? What would happen if you give antibiotics to 11 people who don't need it? Well, there's a problem of resistance. So you have to think through. Now, if you gave some medication, ACE inhibitors, to diabetics, and you could prevent, one heart attack by treating 12, you'd say, I'd do it in a heartbeat. So you have to look at that outcome, and you have to say, what happens if I don't treat it, and what happens if I do treat it? And can I wait until the outcome occurs, and how bad is that outcome? You see. So here I'm thinking the outcome's not that critical. It's not going to cause them to die, right? It may cause them some discomfort. You see how you reason your way through those numbers. But if you just look at this, a 70% relative risk reduction, wow, that's really impressive. And it is indeed pretty impressive. The number needed to treat is very low. That's impressive. But you can't just stop there. You've got to also look beyond it to these things, okay? Now, so we did our number needed to treat. Now this here is the overall, the main result of a systematic review that includes a meta-analysis. This is the result of the meta-analysis here, okay? This thing is called a forest plot. What do you think these are here, all of these?
Confidence interval.
Okay, so, well, what are all these?
The studies,
These,
authors.
yes, these are all the different studies, okay? These are all different studies. And what are they doing? There's a group of studies here. What's this group of studies?
Look at the high quality.
No, look carefully. This is analysis 1.1. These are the preoperative. And then they have a subtotal. Meaning this subtotal has to do, is a meta-analysis of these studies. Then what's this one? Where are we here? Second one. Postoperative. And then what's this third one? Pre and post. And then you have a total. So remember how we said they could do stratified analyses of the three different types and then look at the total. So what do you see here? When you look here, each study has a line. What do you think that little red box is? That's the effect of that particular study. And they have it graphically here and they put it over here as a number. So this is the relative risk of that study is 0.29. And there's a confidence interval, okay? Then here, the line is the confidence interval and the box is the estimate, okay? Now here, what do you think about this study? What's different about this study and this study? Why is this one so wide? What's that?
No effect.
Well, it's not significant, but it has a pretty strong effect. What's that?
Crossing number one.
Crossing number one. Why does this one cross one and that one doesn't? What do you, sample size. This is a much smaller study. Now, what they do, they're going to give less weight to this one and more weight to that one because this one is a bigger study. When they summarize down here, this diamond, that is the pooled estimate for this subtotal, okay? And let's look at this. So up here, this is 0.29 going from 0.11 to 0.75 up there, right? And then this one is 1.17. This one, the inference is big effect. This one, very little effect. But look at this confidence interval. 0.05 to 27.5. That's not wide. That's wide. She knows I said it. That's wide, right? I mean, at one end, you're saying, it's phenomenally good. 0.07, 91, 93% relative risk reduction. On the other hand, don't do it, there's this huge risk. I can't even believe anyone would publish that study. I honestly can't believe it. You hardly ever see that kind of wide confidence interval, right? So do you have any confidence in this study? Killish, not at all. Can't do it. Okay. Now, so each of these has a certain weight. This one has less weight because it's a small study. This has more. This has more. Okay. And then this here is the combined effect. Now, when you see this number here, where did that number come from? It came from all these studies, right? And this is the confidence interval around that. And it goes from 0.15 to 0.5. Okay? Is this wide or narrow? How can you tell whether it's wide or narrow? Well, it's statistically significant, but
It's going to affect the clinical situation.
well, I'll tell you a quick and easy way to figure out whether it's narrow enough for strong inferences, okay, and good confidence. What would you do? And forgetting the issue of antibiotic resistance. Put that on the side. Let's say you had some effect. If the truth were, you see, these numbers are candidates for the true value. This is not necessarily true, but it's saying the truth could be somewhere between these two numbers. What would you do if the truth were 0.5? What would you recommend?
Same as
Take
15.
antibiotic.
The same as 15. So I would say go ahead and treat if all the other things like number needed to treat and everything else being equal. I'd say treat at this end. What would you say at this end? Treat. The inference coming out at both ends of the confidence interval is the same. Therefore, it's narrow enough for confident conclusions. So I'm fairly confident in this number. Now, whether I'm going to do it or not depends on those other things. But I'm pretty confident that this relative risk there's a big relative risk reduction here. Does that make sense? Let's look at this one. This goes from 0.1 to 1.3. What would I do at this end? I would treat. What would I do at that end? I wouldn't treat. So now that's considered a wide confidence interval. It's too wide. I have less confidence in it. Okay? So the confidence interval means I'm 95% sure. It's not 100% sure, but I'm 95% sure that the truth is somewhere in there. Okay? Any questions on that?
But can we depend on that? It means that most of the studies are crossing number 1.
Well, most of them are crossing 1. You're correct. But look, are they all kind of saying the similar thing? I mean, are they all showing that there seems to be benefit? Their estimates, this one is not, but this one is, this one is, this one is, this. They're all showing benefit. So that would be different if you had some up here and some down here. Now, some are showing a lot more benefit, some are showing less benefit. But look at these confidence intervals. They're all overlapping. They all are overlapping. Each of these, there's no confidence interval like that, right? So that is another aspect of the heterogeneity. This looks pretty homogeneous, okay? And in fact, these numbers here, the tau, the chi-square, and the I-squared, tell us how much heterogeneity is there here. This 0 means there's very little heterogeneity in this one, okay? Even though you're right, they all are sort of crossing 1. What seems to be their problem? What seems to be the problem with this one, and this one, and this one? The sample size is too small. That's the whole purpose of this meta-analysis, is to bring them all together so that we can get a more narrow confidence interval and an estimate that's the average. Assuming that these studies are enough alike from a study design perspective, and these results are enough alike that we feel comfortable combining them. Okay? Does that make sense? All right. Now, down here is the total, which is adding, summarizing all of these and giving a weighted average on those. Okay? So the weighted average here is 0.29, 0.16 to 0.5. So in my mind, for this analysis, this is a narrow enough confidence interval because I'm having the same kind of treatment decision at both ends. So I feel pretty confident in this number, that there seems to really be a strong effect here of antibiotics. Okay? Now this is, you then also want to check the adverse effects. And you look here and you say, what are these adverse effects? So outcome is 8 adverse effects, so probably diarrhea and a number of things like that. And so you look here, and there seems to be, in the treated group, there does seem to be some increase in the effects. Okay, so you'd have to look at those effects and say, am I willing to put up with those effects? I mean, is there any serious side effect that could involve death, like C. difficile or something like that? Is that something that's happening? Okay. So then The last thing is this issue of publication bias. And what you have here are, each of these is the studies. And then these are small studies. These are big studies. So what you would expect is, let's say this is the estimate here. This is the line where you have, 0.3. The bigger studies are collected closer, and then down here there's more variability because they're smaller studies, right? Now, where is the area in this plot where you have the small studies with very little effect? So here's one, right? So and small. So it's in this area here that you're looking. This thing is called a funnel plot. And what would you expect to see if those small studies that had no effect were not being published? What would you expect to see here in this area? You'd see less here than over here. Do you see fewer here than over here? There is a little bit. So there's 3 over here. They're pretty tightly clustered. You don't usually see it quite like that. And there's 1 up here. So is there evidence for publication bias? Maybe a little bit. You see? I would expect to see a few in this area, and I only see 1. Of course, there are not that many here either. So, whether there is or not, there might be some evidence of publication bias here. Okay? So what you do is you look around 1 and in the low area, and you see, are there studies missing here or not? If they're missing, then there may be publication bias. If it's nicely distributed and there are a lot of them here, then there's probably not publication bias. But most often you do find something like that. Okay? Okay, we did this lower and upper end. And this is assessing the heterogeneity, looking for the overlapping confidence intervals. Okay? Okay, so what would you do? What would you do here? Would you treat this nurse with antibiotics or not? Is the nurse in our scenario immunocompromised? No, she's not. So would you treat her based on these data? Why not?
Looking at the risk of benefits.
Yeah. Yeah. So what's the risk of doing all this?
Creation resistant.
Yeah. Yeah. I think the benefit may not be that great anyway. And you may end up giving 11 people antibiotics unnecessarily. This could be, and if you have this, how many tooth extractions do you do in a week? A lot. Would you do 25 or 20, something like that? 25 per day. So so you're talking hundreds per week for one dentist. Exposing all those people to antibiotics, from that perspective, no. But from a purely efficacious standpoint, yes, there seems to be efficacy. So, see, you don't just look at the p-value, you don't just look at the effect size, you don't just look at the precision and the confidence intervals. You have to put all that within a context of some reality. These studies are not there just off by themselves and you make clinical decisions based on the numbers. No, you have to put them in the context of a real clinical situation, a public health situation in this setting, and then make a decision. Okay? Good. Any questions from anything that we talked about? Great. Thank you.
Thank you.